Attendees are in listen-only mode.
Thank you for your patience. Welcome to the ECIP webinar Series 4 Save for Start campaign webinar presented by Pete Gordon, Head of Improvement ECIP, Liz Sargent, Clinical Lead Integration and Social Care Lead from ECIP, and Diane Fuller, Deputy Director ECIP. First of all, we just have a couple of housekeeping points. This session is being recorded and the recording will be available to view on our website shortly. All attendees are muted to avoid background noise during the recording. At the end of the presentation, there will be the opportunity to ask questions. If you have a question, please use the raise your hand option in the panel on the right-hand side of your screen. Alternatively, you can write your question in the question section on the panel. During the Q&A sections, we will unmute you to ask your question in person. Thank you, and I'll now hand you over to Pete Gordon. Thank you, Pete.
Thank you, Paula, and welcome to everybody who's dialed in for the ECIP Save for Start session. This is what we're going to cover during the session, and the session will probably last for about 50 minutes. So this is what we're going to talk about. We're going to talk about optimism bias with urgent and emergency care. We're going to talk about a compelling story. We're also going to talk about two different types of approaches, and we're really thinking about the first week after Christmas, the week commencing the 4th of January. So I'm going to cover a breaking the cycle type approach. My colleague Liz Sargent, the clinical lead for integration and social care for ECIP, will cover the MADE approach, which is a multidisciplinary accelerated discharge event, and my colleague Diane Fuller, Deputy Director for the Emergency Care Improvement Programme, will talk about the pros and cons of the approaches, and then I'll finish the webinar by summing up, and then we'll have an opportunity for some questions. So starting with optimism bias, what we often see with urgent and emergency care is people talking about the next new thing, the next silver bullet. And for us in ECIP and the Emergency Care Improvement Programme, we'd say, stick with known good practice. Reducing variation is really crucial to urgent and emergency flow, and also is empowering frontline staff. If you haven't read the document, Transforming Urgent and Emergency Care Services in England, it's also called Safer, Faster, Better. We strongly recommend that you do. This is a really good document. It's not about perfect practice, it's about good practice. And it's taken us quite a while to put this document together, but it covers the whole patient journey from before the hospital, across the acute hospital, and out of the acute hospital. That's one of our key messages to you today, is to read that document. Okay, so when we're thinking about Safer Start and we're thinking about that first week in January and the approach that you take, and we are recommending that people do take a specific approach to reduce the inevitable problems that week brings, you'd probably ask yourself, well, where do you start? And in ECIP, we talk about starting with a compelling story. So this is a story that gets your head and it gets your heart as well. So if I'm a member of your frontline teams, I understand what you're telling me. That won't just be a story about 95%. It will be something that really I understand and is relevant to myself. And these things all make a compelling story. So a high number of outliers in an acute hospital, crowded emergency departments, high levels of acute hospital bed occupancy, all these things are associated with significant patient risk. Additionally, if you've got high and sustained levels of escalation across your system, and this happens each day, every day, and you go, well, that's just the way it happens around here, all those things make a compelling story. And one thing's for sure is the first week after the Christmas holiday period will be problematic. When we're sort of building on the compelling story, the evidence is really strong here. Here we go. A study by Richardson found a 43% increase in mortality at 10 days after admission through a crowded emergency department. 48% of people over the age of 85 die within 1 year of hospital admission. If you put that another way, if your loved one, think about, one of your family, a frail older person, if they had 1,000 days left to live, how many would they choose to spend in hospital? And how many of those days would you want them to spend in hospital? 10 days in an acute hospital, that could be an acute or community hospital, leads to the equivalent of 10 years aging in the muscles of people over 80. If you're an outlier, there's a link between outlying and an increased mortality rate. So, key message there is outliers are unsafe. And the next slide up here is from a Midlands hospital who made a number of improvements. And one thing that this article really clearly shows is that if you can reduce bed occupancy, there's a definitive link between a reduction in all markers of mortality and an improved 95% performance. So we would say that all those things make a compelling story. But also, you'll have a graph in front of you at the moment, which shows percentage of patients waiting less than 4 hours in accident and emergency from arrival to admission. You can see last year, 2014 and 15, it's in brown, and we can see this year in blue, tracking below that. And if you were to put this for last year and the last 5 years, at this, part of the year, it is historically the time of the year where we see the most crowding in emergency departments and when systems really struggle. And that's why we're recommending for all ECIP systems that they run a safer start approach to the new year to mitigate those inevitable risks. Now, when we think about flow in and out of a hospital, we'd often think about it like this: some patients coming in and some patients going out. But sometimes it's a bit like this. So this could be a weekend. So some more patients coming in and slightly less going out. But there's one day of the year when it's like this. And, I don't think you need to be Sherlock Holmes to work out what day it is, but it's coming up fairly soon. And this is the Christmas Eve effect. And so think about why you get the Christmas Eve effect. Well, there's a real clear desire to make it happen. Patients are clearly identified that actually, this patient is ready for discharge and can go home before Christmas. Obstacles, importantly, are overcome in real time. And nothing is left over because tomorrow is too late. So this really is a great example of actually, can we get them home for Christmas? And so if we take that effect, and if we think about it, and so we can do all that before Christmas, is the week after Christmas. Imagine if we had a week of Christmas Eves. And that's really what we're saying to you. We're saying that actually the Safer Start campaign is really about, having a jump start approach to January. And here's a quote from Albert Einstein: insanity is doing the same things over and over again and expecting different results. We sort of know what's going to happen, and that's why we're advising all ECIP teams to take on, adapt one of the approaches that we're discussing on this webinar today. So I'm going to talk about the breaking the cycle approach. It's also been known historically as the perfect week. We don't actually really advocate the use of the word perfect week because it tends to be, it doesn't resonate with frontline staff. All we say is give it a word, give it a name yourself. Could be Jumpstart January. It could be Operation Fresh Start. It could be breaking the cycle. Give it a name that resonates. In terms of the week itself, we'd always say that whole system is better than just an acute week. It's about us all being in this together, having a compelling story, and having whole system partners really helping the acute hospital to pull patients out. Some possible commitments: cancellation of all non-urgent meetings and reducing unnecessary email traffic. We'd strongly recommend that during this week that there are two senior reviews by a consultant on every ward every day. This may involve the use of non-clinical SPA time. We'd encourage the increased visibility of senior staff, and we'd really, really encourage the deployment of ward liaison officers. So these are people who typically might work in admin functions such as HR or finance. And what we like to see is one of these people allocated to a ward, and they work at a sort of bronze level, and they are working sort of to the nurse in charge of the ward and the doctor and therapist on the ward to really help them hunt down delays. And when we see this work really effectively, we see something called marginal gains improve. So actually they chase down lots of small delays. They don't repeat other people's jobs, These roles prove to be popular for the people doing them. It's important that they're brief before you let them loose, but they also appear to be really popular with the ward teams. It's important for executives to give permission to frontline staff to get on and do things. And you know what? Sometimes you've got to rock the boat. It's important to stay in it. But, you know, during this week, people shouldn't be looking up the whole time. And we also encourage people to follow, you know, things, simple rules like the safer patient flow bundle, which I'll very briefly cover later on, and also the red days out, the red day being a day which is of no value. So during the week, with a break in the cycle type of week, we'd say, you know, have a really definitive leadership and management structure in place using bronze, silver, and gold. There needs to be a balance between really good control and grip, but really letting the frontline staff free to deliver the shared purpose. So here's an example of a shared purpose. So, you know, we say to you as a system, have a shared purpose, which reads something like this. This one is hospital is not a place of safety for people that are medically stable. We'd encourage daily wash-up meetings to understand the lessons learned. But above all else, you know, above all else, if these weeks, and we've seen some great weeks, and we've seen some mediocre weeks, and we've seen some pretty poor weeks, we'd say that above all else is to get a social movement and develop a buzz. I've mentioned bronze, silver, and gold. So the bronze level is really where the ward departmental level. And what we'd say here is any issue during this week, because you're trying to push the week as close to a major incident as possible, any issue that can't be solved within 2 hours, the ward liaison officers take to Silver Command. And in Silver Command, you've typically got a divisional general manager, the head doctor for the division, a head nurse, a logist, maybe some other support people. And their duty then is to log the issue, and actually they then have about 2 hours to resolve that issue. Any issue that they can't resolve goes to Gold Command. We'd say Silver Command should probably meet twice a day, and probably linking with Gold Command once a day. And the Gold Command is typically the executive team. And if there shouldn't be that many issues coming up to Gold Command, but those that do should be a commitment that those issues will be dealt with. We'd also say with the executive team, you know, during a break in the cycle type week, is that they actively visit the wards, not to inspect or anything like that, but really to say, actually, you know, how are you doing? And then maybe make a commitment after the week to visit those wards once weekly. In terms of here, we've got a sort of weeks become days, days become hours, hours become minutes. During this week, in that week in January, that's the sort of mantra we'd be saying. Hours become minutes, days become hours, and weeks become days. And my screen is just frozen. One moment. Okay, so you've sort of got this thing going on really, is where problems are resolved in real time. And that's really important. So what we're saying is you do today's work today. And that would be the same with the MAID approach as well. In terms of preparation, we always encourage an ask and offer approach. That could be in a hospital, the various departments saying, actually, what I ask of my colleagues is this, and what I'm going to offer for the week is this. And we'd also encourage a whole system to run an ask and offer session, whereas actually, you know, what I'm asking of social care is this, and what social care is asking of the acute is this. So an ask and offer session, and it's as simple as that. I've talked about birds. Well, you know, in all reality, I'll be honest with you, you know, the best weeks that we see in terms of the week itself and afterwards are the ones where they get a social movement. A social movement really involves everyone understanding what the purpose is, a willingness to participate, but also a willingness to get on and do stuff. And, you know, when we see people taking a risk that benefits patients and rocking their boat but managing to stay in it, we tend to see success. And it's sort of more of the picture here of Martin Luther King on the right than the one on the left. You know, the one on the left doesn't really grab your frontline stuff. I've got some key performance indicators for you, or I've got a dream. We're really up for this. That's more about your social movement. We'd recommend using some measures. Some outcome measures could be the number of empty beds at 8 o'clock. Process measures could be the percentage of patients discharged before midday, and a balancing measure could be the number of readmissions. So what I'm going to do now is I'm going to hand over to my colleague, Liz Sargent, who's going to talk about the MAID approach.
Hi everybody, it's Liz Sargent speaking. Pardon? Can you, right, I can't ask if you can hear me. So the MADE approach is a multidisciplinary accelerated discharge event. This is an approach we've taken in a number of hospitals already, and the purpose is slightly different and is linked to the fact that decision-making is capacity rather than beds. And we think that in the week after Christmas or during Christmas, decision-making has often slowed down slightly, and this is an attempt to speed it up again. So the idea will be to challenge whether every patient in every bed on a number of prescribed wards in a hospital actually needs to be in hospital. So that will be challenging clinically whether they still need to be in hospital, and for those who've passed being medically optimised, what we can do to get them out. The biggest opportunity is in the simpler patients, not the complex patients you've been discussing for weeks. So the idea is that we review the relevant inpatients to assess opportunities for more rapid or even same-day discharge, based on examining how far individuals are from being medically fit, and applying constructive challenge of rules that seem to get in the way of why people can't go. It also allows us to highlight local myths and misunderstandings about services and what could be managed in the community, and vitally to improve communication and understanding between all parts of the system, because it will involve all the parts of the system being in a room together around a patient discussing what would be best for them. Oh, I can't make the slide go on. Pete! Oh, thank you. So the process is that a team is set up, and I'll talk about the team in a minute. The system agrees which wards they're going to focus on during this process and looks at all the patients, predominantly those not viewed as complex discharges, as I said. Typically, this will mean acute medical wards, respiratory gastro, and some surgical wards. And if in the past we've built this on the back of an ECIP length of stay review, where we have high numbers of patients who are in needing treatment still in hospital, but nobody can be really specific about what that treatment is. And it's often patients waiting for a review by a doctor of test results before they can actually be discharged. And it will bring forward the speed of those decisions. The team need to plan to be on the wards for 60 to 90 minutes, although on the first day you do this, it may take not far off half a day per ward, because it takes a while for everybody to get used to the process and the questions that really help. Pete, oh, sorry. So we meet with the ward manager or shift coordinator, so the acute trusts, and we think it will be helpful to review some of the community hospital wards as well. Should be warned in advance that this is going to happen and be available to meet with the team, possibly around the whiteboard, but not necessarily, because if it's in a public place, it's too many people to have talking loudly, and it's better to meet in a separate room. There's a short review of progress against each patient's management. If the registrar or consultant is available, that would be the absolute best option. And looking for areas where further action could be taken to speed up treatment and discharged. If required, the clinicians in the team may look in the notes, and we've added a portion to this particular MADE process where we will have patient representatives who are DSB checked and have had training in how to talk to patients, so Health Watch type people or from some of the voluntary organisations, who at the same time as the conversations are happening with the ward teams will go and talk to the patients on the ward and ask our 4 standard questions and see whether the patients have been given the information to enable them to answer them. So that's the what's wrong with me, what's being done to fix it, what do I need to be able to do to go home, and has anybody asked me, and have I been told when I'm likely to go home. It's vital that somebody is taking action notes as you go through this, because people will come up with ideas come up with ideas about, sorry, somebody just came into the room, ideas about things that would enable faster discharge. And you need to be able to follow these through on that day and going forward. So the team needs to comprise a GP with good knowledge of urgent care and who's willing to offer constructive challenge. So they need to be able to sit and talk to the clinicians and say, so if this person were in primary care, I would be able to do this, this and this. Why do you need to keep them in hospital to do what you're doing? And this is where the dialogue creates an education and communication that should work beyond the MAID process. You need an experienced nurse from the community, a community matron or similar. Senior operational lead for your intermediate care services, and an acute trust therapy lead, because they need to understand whether therapy decisions are getting in the way of discharge and consider whether with the community staff those therapy decisions could be made elsewhere. You absolutely need a social work team manager or higher grade, because we need people who are able to break some of the existing rules and agree to fund things that actually frontline staff might not know they're able to do. When reflecting on the week afterwards, it's useful to consider what would have needed to be different for frontline staff to be able to make those decisions. A trust pharmacist is essential, because if you suddenly create a large number of extra discharges, they need to be warning their department in advance that this is going to happen. I've talked about the patient representative, and a commissioner is also vital, because sometimes we need to break the rules about what services out in the community can do, obviously as long as it's clinically safe and appropriate to do so. And if we're reviewing the community beds in systems, we suggest it's worth considering having an acute consultant being part of the team out in the community review. Thank you. I'll hand over to Diane.
Hello, Diane. You're now unmuted. Hello, Diane. Can you hear us? I don't think she can hear us, Pete.
I think I have a caller.
Okay, thanks.
Okay, so thanks, Liz. So what we've had there is basically two approaches. One is the breaking the cycle type approach, and one is the MAID approach. In terms of the pros and cons, the key thing with both these approaches is when you get a whole system focusing on a shared purpose, and when you really get a system coming together to really, reduce the number of stranded patients, and also do what we sort of know works each day, every day. Either approach is effective in our experience. One of the questions that we often get asked with these type of things is, well, they seem very short term, and that's right, actually. So we quite rightly get asked, how do you sustain things after the week? And we're quite clear about this. Is we say follow, simple rules and what we know works across urgent and emergency care. So as I said before, this document transfer for the urgent and emergency care services in England, also known as Safer, Faster, Better. This covers the whole journey from before hospital, across hospital, and after hospital. One of the big things that we see is we see variation. And during this first week of January, if you really try and stick to what works, plus a little bit more, and focus on reducing variation, we think you will be able to mitigate some of the effects. In terms of following simple rules, these are some examples of simple rules. We often advise sites and systems, and we're talking really about an acute hospital, it could be a community hospital as well, is to use something called red and green days. And a red day is a day which adds no value to a patient. So basically I'm sitting here or lying here in a bed, and nothing happens. And a green day is a day which adds value to a patient. And what we see starts when they really focus on this, they may visualize it and make it really visual, but also they start talking about it. How many days tomorrow and today are we planning for our patients to be red? And what we find is when you really squeeze the red days, you see a reduction in length of stay. Another example of a set of simple rules is following the Safer Patient Flow bundle. So, for example, my colleague Liz, who's just been on there talking, who's our lead for integration and social care, when she's done this in trust, she's seen, significant length of stay reviews and actually a reduction in, the number of stranded patients. Just to go over the bundle, it's that, think about it during the first week in January, are all your patients having a senior review every day? And during that week, we'd say, consider having it twice a day. Do all your patients know the answers to those questions? What's going to happen to me today? What's going to happen to me tomorrow? And what do I need to do, in my words, to get out of here? And in our experience, I'm sitting in a workshop in a part of England at the moment, and we had that very conversation about an hour ago. It's actually not all our patients do know, or their loved ones know the answer to those questions. In terms of the F of the bundle, that's the flow early. So during this week, we'd really encourage you to up the ante with this. So those wards that should take a patient or have 2 or 3 discharges a day, these are typically medical wards, should pull their first patient up by 10 o'clock to create that space for those incoming patients. If not, if you don't do these things early, what you'll do is you'll get big queues forming in the evening. And the bottom line is that that's not safe because you haven't got a certain level of capacity being people rather than beds available. The E is earlier discharge. So, here the biggest constraint that we see is TTOs in the letter. It's not interesting, but it is what we see consistently. So we'd encourage those to be done the day before or to be done in real time. If you can get a third of patients out, you'll be doing well. And we know that this is achievable. And the R of the bundle is the review of stranded patients. And this is where I think particularly the MAID approach works particularly well. And so we classify a stranded patient as a patient with a length of stay of 7 days or greater. And some people don't like that terminology. We're very comfortable with that because we see a lot of patients that are stranded in the acute hospital. This isn't just about doctors. This is about a whole system, multidisciplinary team approach. And often when we bring people from outside of the acute into the acute because they're less risk averse, we see some great things happen there. So in summary, whichever approach you take is okay, but we would advise you and recommend that you do take an approach, and this is rather tactical to mitigate the risks. You're going to need a simple implementation plan. We're talking that's not very complicated. Getting everyone on board is more important than anything else. And communicating using absolutely every method possible. So the people know, does it feel like it's got really good clinical engagement? Do your Band 5 staff nurses know? Your Band 5 therapists? Do your pharmacists know? Measurement is important to see how you're doing those outcome process and balancing measures. But as well as that, it's the stories. People get really, stories really capture the heart. And in terms of evaluating it, whichever approach you take, we'd say do a very quick evaluation and confirm next steps. And, hopefully it will enable you to kickstart the new year in a better way than you would have done if you hadn't actually done it. And on the last day, it's worth having a wrap-up event of some shape or form. So led by the senior team where people are thanked for their efforts, stories are shared, results are shared, and there's a real clear commitment to next steps. Okay, so that's myself and Liz. That's our webinar finished, but we've got an opportunity now for questions. So I'll just hand back to you, Paula.
Okay, thank you, Pete, and thank you, Liz. Just to let everybody know, if you've got a question, please raise your hand, use the raise your hand option in the panel on the right hand side of the screen, or you could alternatively write your question in the questions section on the panel. I'll just give everybody a couple of minutes just to do that. If you do write one in the questions section, I'll write it out. I'll ask the question for you, sorry.
That was the wrong time.
Okay, just a few more moments. Just give it a few more moments, okay? Like I say, if anybody has a question, use the raise your hand option in the panel on the right hand side, or you could type your question in the questions section on the panel.
Hi, Pete, it's Deb. Can you hear me?
Yes, I can hear you.
Oh, hi.
Hello.
Pete, hi. Can you give some examples of impact that you've seen, say, after a breaking the cycle event or a discharge event, in terms of maybe how many beds have been released, how it's improved flow, that kind of thing?
I can do that for a main event. Oh, sorry, you go first, Pete.
Well, no, actually, Liz, why don't you go first with the MAID event, because that's less common than a breaking the cycle approach.
Right, so two MAID events, but one in quite a small hospital of about 180 beds, and we shifted forward the discharge of 47 patients over the next 5 days that wouldn't have occurred at that same time if we hadn't had the event. And it gave that trust significant capacity for quite a long time afterwards, not least because we'd begun to change the thinking and the thought processes that had been set going on the day continued thereafter. We've done them in some other trusts where it hasn't been quite as successful as that, but it has increased the discharge. The feedback we've had is that it made people far more aware of what community services could do. And it allowed us to take some barriers out of some processes in another trust that made the whole discharge process slicker. But the big win was 47 out of 180 beds was quite a lot. They actually achieved about 70 discharges in total, but we think it was 47 additional.
Good,
Yeah.
Thank you, Liz.
Okay,
and I think with the breaking the cycle, we've seen varying results, Deb. To be honest with you, so we've seen at one end people end up in a rather large teaching hospital with 150 empty beds, and then we've also seen some where they haven't got the social movement bit right and the approach right, and it's resulted in a lesser impact. But our big thing would be, if you get it right, you should see a reduction in the number of occupied beds at 8 o'clock every day.
Thanks.
Okay, we do have a question, Pete and Liz, from Alison Kemp from Coventry and Rugby CCG. I'll just read it out. Where systems have had a programme of perfect weeks in place, how do we ensure that we mobilise and maintain a buzz? Last perfect week in November, next due in end of Jan, i.e. risk of business as usual.
Yeah, so this is a really, really important point, because actually I'm aware of this organisation, and they ran one in the summer, which was the organisation I was referring to, which had about 150 odd beds empty, and I think they ran one a month or two ago, which didn't have the same respect. The trick is with all this social movement stuff is you've got to get people bought into the shared purpose, and that's everybody bought into it. So that's everybody across a whole system. It works particularly well in our experience when it feels clinically led, and not just about doctors. That would be, therapists and nurses as well. But everyone buys into the shared purpose, and then there's a commitment. So it's not and so we do sort of think it's quite good when an organisation positively plan to run one of these weeks every quarter, but it has to be almost seen as this is part of what we do really. And also after it, we like stuck records sometimes in ECIP, about you've got to stick to those simple rules and reduce variation. You know, we often see very, very complicated rules which people find it hard to navigate around. And we'd also say in every organisation, where's that triumvirate of the, you know, the nurse director, the doctor, and the operational person? Are they all bought into it? When we don't see people buying into it, for example, a shared purpose could be hospital is not a place of safety for people that are medically stable. You know, what we'd do is we'd say, get a shared purpose, and if you're going a bit off track, come back to that shared purpose. Liz, have you got anything to add to that?
Yeah, no, and you can, I've found a system recently doing this kind of stuff by having the community coming in on a regular basis, and their shared purpose is driven by talking to their population, is we're going to measure the amount of time people spend in their own homes, and it's really, that's really given a buzz to the staff. If you talk to them, they really are clear why they're coming to work and what they're trying to deliver every day. So you can't underestimate that shared purpose. And if it's around a patient, it's very difficult or unlikely that anybody will ever disagree that that's what everybody wants to achieve.
Okay, thank you, Liz. We've got another comment, and it's from Bob Pearce, and he's from Gloucestershire Hospitals NHS Foundation Trust. In response to the comment just now about sustaining change, we've been running safer weeks each month for the last 3 months, and will continue throughout the winter. We are building on the marginal gains approach.
That sounds really positive, and if you're adhering, Bob, to the principles of the Safer Patient Flow Bundle, that's all about marginal gains. So that sounds to me more like a comment. That sounds like very, very positive. Would you agree, Liz?
I would agree, and I'd put a slight challenge. There are trusts that now safer is business as usual, and is happening every day, every week, and not once a month. That's the only comment I would make. That's not the full perfect week. It is just the Safer Flow Bundle is the way the ward works.
Okay, thank you. It doesn't look like we've got any more questions at the moment. So just to let everybody know, if you do think of any questions, we can pass them on to the presenters. If you'd like to email them to ecipinfo@nhselect.org.uk, and like I say, we'll pass them on for you. I think this now brings us to the end of the webinar session. Thank you for taking the time out to provide us with this webinar, Pete and Liz. Just a quick reminder that the recording of this webinar will be available on our website shortly. Goodbye from all of us, and thank you for joining this webinar. Thank you. Goodbye.
Thank you.